this whole day symposium, but certainly to the afternoon sessions, the keynote sessions on the for our perinatal mental health symposium. My name is Sophia Vinogradov. I'm the relatively new department head of psychiatry. I know some of you in the room, but not all of you. For those of you I have not yet met, welcome. We're really excited and pleased to have you here as part of the greater community dedicated to the well-being of mothers and infants and families in this important area. You probably already know this. I suspect it kind of has come up in conversation this morning, but there were several goals for this symposium, and one of the goals was, of course, just to increase the community of sharing information and education and knowledge and awareness across specialists who are doing work in this area. Another goal was to really start dialoguing explicitly, again, I think something that you all know firsthand, about the multi-generational impact that really a focus on perinatal maternal health will have, that it's not just for a mother or not just for the mother-infant dyad, but it has a wonderful ripple effect, right, throughout families and communities. And then thirdly was just to highlight something I'm very excited about personally, which is the fact that we are now within the Department of Psychiatry really getting an initial, so maybe it's even beyond a toehold in this area, and that is really thanks to the energy and vision and commitment and passion of several people, probably at least well known to you, and that's Katie Thorsness, who will be graduating from our psychiatry program, who's just held this deep commitment to women's well-being and women's mental health, but also to her mentors, Benita Dieperink, and Helen Kim at the HCMC program, who of course have done seminal groundbreaking work in this area for the community. And then also we have a couple of other faculty who've played a real role in this as well. So what we've been able to do is and I say we, it's the royal we, right? What this outstanding group has been able to do is to start creating a women's well-being program here in collaboration with the Department of OB that has been really an outstanding success. And I can tell you, a few months ago, I had a colleague who had some needs for his wife, and I was very delighted to be able to get this person connected quite quickly with this outstanding program and with kind of the good outcome. So kind of speaks to both how well the program is running already in its early days and the importance of one other piece. So right now we've been focusing on the clinical programming, but there are beginning to be some of the elements coming together to create some real ability to ask some research questions. So there's, as I think all of you know, there's still an incredible amount that we don't know about perinatal mental health, about optimal ways of understanding what's going on when women are kind of dealing with a number of challenges and issues, how to understand it, how to explain it to them, how to explain it to ourselves, how to understand the underlying biology and psychology, how to tie it into that person's unique cultural and social context, how to think about what are the optimal treatment recommendations to make, how to follow that person's trajectory and make the appropriate adjustments to optimize, again, the health of the individual and the family. Many open questions, and we're at the point now where I think we have a critical mass to begin thinking about how to ask and begin to answer some of those questions here, in Minneapolis, through these extensive collaborations among the different programs. And we have a donor who's potentially interested in beginning to fund some of this work. So again, many elements are coming together to gel, to sort of take all of this work to another level, to a level in which I think will not only be serving our communities here, but potentially serving kind of the greater knowledge base kind of in this field, even nationally. So I'm going to stop. I could go on for a while, but I'm going to turn it over to Katie Thorsness, who's going to tell you a little bit about the afternoon organization.
Thank you, Dr. Vinogradov, for that introduction. Good afternoon and welcome. It's so lovely to see so many disciplines, levels of training, and organizations represented here for our first annual perinatal, maybe annual, that got ahead of myself, Perinatal Mental Health Symposium. An additional welcome to those listening live. The University of Minnesota Department of Psychiatry Women's Wellbeing Program is sponsoring the afternoon of speakers for this symposium for you to learn more about the identification, treatment, and impact of perinatal mood and anxiety disorders, also known as PMADS. I'm Katie Thorsness, like Dr. Vinogradov had said, a fourth-year psychiatry resident at the university here specializing in perinatal mental health. And along with Emily Pasetsky, Christina Ragstead, and Victoria Valena, who is here in spirit. She's working really hard. She's our nurse partner and is covering all of our patients like nurses often do. And so she's unable to be here today. But in October 2017, we launched the Women's Wellbeing Program here within the Department of Psychiatry's outpatient clinic. The program provides reproductively informed mental health treatment in a multidisciplinary team model and strives to support women and their families with tailored evidence-based treatments as they navigate the transition through the life cycle to promote positive outcomes and healthy functioning across multiple generations. The clinic also serves as an entry point for delivery of comprehensive maternal mental health intervention and early intervention for at-risk offspring. Providing our community with reproductive informed psychiatric care supports the mental health of multiple generations, and supports the bedrock of our society, the health and emotional well-being of mothers. This symposium is truly a group effort to connect our community, learn from some of our own experts, and to increase collaboration and identification of PMADS. We thank you for joining us, and we also thank the Department of Psychiatry, Dr. Benita Deepbrink, Dr. Dee Bass, Postpartum Support Minnesota, and our generous speakers for their support to make this day possible. Here is a look at our afternoon agenda in the bottom half there. We're going to start by looking at the multi-generational impact of perinatal mental health, moving into a discussion under the biology of perinatal women, take a short 15-minute break with refreshments, and then come back for early childhood mental health in the perinatal period, and closing with a few clinical subtopics. Each speaker will provide about a 25-minute talk or so, leaving 5 minutes at the end of each talk for questions. Of note, we'll be sending out a brief email feedback from the forum following the conclusion of our symposium, and would appreciate any feedback you have and thoughts as we think about possible future initiatives. A link to the slides will also be provided after the symposium for your access, as well as a recorded session of this afternoon. So please join me in welcoming our first speaker under the multi-generational impact of perinatal mental health, Dr. Ann Gearity, faculty of both the University of Minnesota Department of Psychiatry, as well as the University of Minnesota Infant and Early Childhood Mental Health Certificate Program, who will be presenting Assessing and Enhancing Parental Reflective Capacity, an important aspect of perinatal work.
Katie, just show me this. Nope. Okay. Thank you, Katie, and thank you all the organizers of this. What I'm going to talk about is reflective capacity. I'm going to introduce you to it. Many of you probably know it. How many of you use that term? Okay, and just walk us through why I think this is an important foundation for perinatal work. So reflective capacity is very grounded in attachment research. Now we know in Make Way for Ducklings, the ducklings know how to walk in a line, come where they're called, and learn the basics of survival. And so much of attachment research is really about survival. What makes us different than ducklings is that we not only have to follow our mothers, we have to understand. And we have to understand social interactions. And we have to learn about our social world so that we can develop an awareness of ourselves and our minds. So reflective capacity came out of this attachment research and trying to look at what are the mechanisms that allow children and parents to communicate in a way that form the attachment bond, and what is a mechanism that allows us to use when we work with distressed parents and their babies to facilitate that connection. So beginning communication is always about reflection. Some of these slides didn't get their words right. So Dr. Metcalf, and from this book, talked years and years, this is 1999, and he talked about going into the neonatal, into the nursery shortly after babies were born, and he demonstrated how adept babies were at mirroring and modeling, that he could put out his tongue and a baby would respond. Now, this is very, very early sensory communication, but as you can see from the picture, we really quickly interact with babies in ways that assume they have a mind, not just they have a tongue. So this dialogue between me and my first grandson was a critical dialogue where he and I were getting to know each other, and I was discovering how smart he was as he followed my imitations and delighted. And that kind of communication we know is so important for the young baby and mother to make that experience real, that we know each other. Reflective functioning has been described, and I use the words, the papers from Ariadne Slade. I'll tell you why, but I just stayed with this one author. She described it as the human capacity to relate and process interpersonally, and that is linked to meaningful, predictable ways of understanding underlying, unobservable, changing dynamics, feelings, and intentions. And what we know about infancy is that the baby has to communicate in ways that are underlying and often unobservable. And we count on the parent to be able to recognize this communication and make sense of it. Reflective functioning involves the capacity to understand one's own mind and others' behavior in terms of underlying mental states and intentions, and more broadly, as a human capacity that is intrinsic to affect regulation and productive social relationships. So this ability to know about mental states and intentions is really critical. This is how we go underneath behavior. We know that reflective functioning comes out of an understanding of mentalizing. Mentalizing is the metacognitive process about knowing myself and others. Mentalizing is not what I think, but how I think. Mentalizing is the capacity to understand one's own behavior and that of other people in terms of underlying mental states and intentions. And more broadly, it's the intrinsic human capacity that's crucial, again, for affect and productive social relationships. I realize I repeated myself. So this idea of mentalizing is that I can know about my feelings, my thoughts, my intentions, my beliefs in a way that I can symbolize them into words. Now, often what we see in very distressed families or adults is this inability to know my own thoughts, my inability to know how my mind is working. So we step in with our interventions, and often they can't work because people can't know. Jesse will talk more about that. I'm not getting ahead. So this dyadic regulation that is so important in the mother-baby experience regulates affect and behaviors. And one of the things we know about babies and mothers is that the baby is affected by the mother's regulation. The mother is also affected by the baby's regulation. You know, everyone knows that when the baby's sleeping through the night, how does the mother feel? Right? And when the baby's not sleeping through the night, what happens to the parent's regulation? So this idea, not that they are equal, but they impact each other. So we're always thinking about dyadic regulation. Oh, let me go back. In attachment language, we call this expectancies and strategies. Now, when Bowlby first wrote about expectancies and strategies, he was talking about almost a behavioral level of understanding. We've moved very far in our research to understand that expectancies and strategies are actually mental constructs that help me know what will happen. And we know these mental constructs get formed very early. I have a lovely story from my third granddaughter. As a 3-month-old living in an old South Minneapolis house, when she'd wake, she'd cry. And if she heard the stairs creak, she would stop crying and wait. Now, if you had the bad judgment to go put a load of wash in or do something else, her contentment would change and she would become quite distraught because it hadn't worked. And this idea of babies learning so early on what works in the interaction with their parent is crucial. Reflective capacity allows the adult to integrate, and I'm using the female pronoun. This is equally true of fathers. It allows the adult to integrate what she internally knows, remembers, and understands about her own childhood. We know that so much of how we parent is almost an intrinsic and implicit memory from when we were a child and parented. We carry those feelings forward, but also her ability to hold the idea of her child and her child's experience as separate from her own. So there's this tension that happens when you become a parent where you have to know yourself and know your child. You have to know the space that you coexist in, but you also have to know that there's a difference. Early in my work at Children's, I learned that one of the most vulnerable population were crack-addicted mothers because they didn't care about eating. And they would forget to feed their babies because they didn't think about eating. So their ability to hold their child as separate from them was diminished by their addiction and their distress. This knowing is more than knowing about being able to recognize another mind. It's really about recognizing another mind even as this mind is emerging and being created by these interactions. Sometimes researchers will say the baby knows she has a mind because her mother says she has a mind. And again, if you think of normal development, watch a mother of a 2 or 3 month old go to the grocery store and say conversationally to this baby, let's get vegetables tonight. How about broccoli? Ooh, you don't like broccoli. I remember that now. And there's this capacity to start to think about your baby as having a mind and recognizing that I need to protect that mind and consider that mind in making decisions. In infant mental health, we talk a lot about engaging the mind energy of the infant. Many of you know this book, Are You My Mother? I use it to teach, to remind us that while attachment is certainly parent-driven, we now know that babies are very active participants in this process. They're not just blank sheets. They come with a lot of information and intention. And the more that the parent can engage that mind energy, the more satisfying it is. Because the parent is constantly making sense of experiences. So at the core of reflective functioning is not just seeing the other's mind, but making sense of it in a way that the baby is not yet capable of doing. So the mother who says, "Ooh, you don't like broccoli," is talking to a nursing baby who doesn't have a clue what broccoli is, but is starting to learn that some things make her feel good and not so good. Much of what a parent must do, especially in this early relational time, is make sense of her child's signals and communication by decoding sensory and nonverbal cues and interactions that form the basis of this connection. This essential messaging bridge, these essential messages bridge the space between them and permit this dyadic knowing and provide the foundation for increasingly complex knowing about the baby's self and about the social world. So the mother not only provides survival, but she provides orientation to the larger world. And this orientation is how the baby moves from connecting to exploring. When we talk about attachment, we never want to lose the second from the first. Attachment is not about I love my mother. It's about I love my mother so I can go out and see the world. The benefits to the child are profound. Early relationships create the opportunity for the child to learn about mental states and determine the depth to which social environments can ultimately be processed. This is again a reminder, the child is looking for the orientation to make sense of the larger world, but it has to start with making sense of myself. So we see parents very actively explaining to their babies, "Oh, you're upset because you didn't sleep enough." or, oh, you must be tired. Nothing harder than saying to a toddler, oh, you must be tired, at which point he says, I'm not tired. And we say, oh, we think you are, right? But in that dyadic communication, the baby is organized. And that word organized is a critical construct that the parent provides the child a sense of organization so they can feel regulated. When reflective capacity is compromised, it is the mother's capacity to understand the nature and function of her own, as well as her child's mental states, that will allow her to create both a physical and psychological experience of comfort and safety for her child. This psychological and physical safety for her child is often a safety for herself as well. Again, if you think of dyadic regulation, the parent is highly dependent on that the baby to help her develop this new sense of herself as a parent. Safety comes from effectively keeping her baby in mind. Distress is intensified when she cannot know or finds that baby confusing or unresponsive to what she expects. That's where the distress occurs. It's not just that she can't take care of her baby, but her baby confuses her, as often happens in very distressed parents. Their baby becomes confusing or unknowable. Reflective capacity builds on research about intergenerational transmission of attachment. We know that there's now robust findings about a reflective capacity, and many of us bring this quality to parenting. We use a description high or low reflective capacity. Many of us in this room are probably high reflectors, right? We do it all the time. I remember watching a basketball game on TV when the UMN was playing, and a player was being interviewed with his mother. And there was a difference in racial presentation. And while everyone else is thinking about basketball, I'm thinking about, I wonder what that's like for that kid. I wonder what that was like growing up in Hibbing and being an African-American boy. I'm constantly reflecting. High reflective capacity lends to greater psychological insight. It can also be a downside, but it tends to help us be interested in what is happening in the other and interested in what is happening to ourselves. Low reflective capacity has been shown to be much more prevalent in families that struggle with significant adversity, in families who have lived through trauma, and in intergenerational families where parenting has been difficult. People shut down on reflection, and then they can't see the other child. They often dismiss the experiences. When adversity interferes with parental experience, reflective capacity often suffers. It becomes so much harder to see the other and maintain a mental awareness of the other when you feel threatened. So you can see why this capacity can become an important focus of our interventions. Assessing reflective capacity has now been validated and replicated. There are actually 2 tools that we use in the community. I like these tools because I can borrow, even when I don't use the formal tool, I can borrow some of the questions. One is the parental development interview. That was an addendum to the adult attachment interview. This was developed by Arietta Slade at Yale in 2004. The second is a more robust model, the working model of the child by Charlie Zena down at Tulane, and that's been revised since 1986. There's a new version just out. These are very accessible tools and are very useful in assessing an adult's reflective capacity and reflective functioning and having ideas. So the quality of the tools might be, what do you think your baby is needing now? And the answer is really to look at whether the parent can imagine what's happening to that baby and have a response that's coherent to the baby. A low reflective functioning answer might be, how should I know what that baby is wanting? She cries and cries and cries. She just cries to make me crazy. I don't know what to do. right? A high reflective response may be, I don't know what she wants. She cries a lot, so I try to imagine. I don't think she's hungry. I don't think she's wet. Sometimes I don't know, but I keep trying to figure it out. Do you see, it's a process. It's not that you know the answers, what to think, but how you can join the other in a process of thinking. There's an intervention model that I thought I'd mention. It's called Minding the Baby. It was developed at Yale. It was started by Linda Mays and Arietta Slade and others. It's a home visiting model where a public health nurse and a clinician, usually a social worker, spend time with babies, with mothers prenatally. The idea, it started with adolescent mothers, and the target was to identify mothers at risk before they had the baby, so that they could think about helping these mothers think about their babies. So the visits happened prenatally, and discussions would be, what do you think your baby would feel? What do you think your baby will need? What do you think it's like for your baby living on the 3rd floor? How will you help your baby get up all these stairs? So it's very practical, but it's really directed at this capacity. The goal was to assist mothers in becoming more reflective in her interaction with her child, promoting a learning experience to foster the management of multiple demands in their lives. So again, the end point is not just to be reflective, but to be reflective so that you can manage other things. That's really the important. Reflective functioning is seen not only as an essential capacity that promotes connection, but also as a protection against subsequent adversity that can disrupt primary maternal care. The research findings have been significant. This is a study that was done out of Yale. When the parent does not recognize her own and her baby's individual and separate emotional state, subsequent effect on behavior, there is a risk of miscuing one another, resulting in miscommunication that can lead to poor emotion regulation and elevated stress levels. Right? So we know how important company is for stress. Dr. Gunner's research at ICD has been very clear that company reduces stress, and when the parent is not able...
Found on the web for relation.
My goodness, I thought it was going to tell me my time. When the parent is not able to provide company for the baby, or the baby is not able to provide company for the parent, stress increases. Now, many of you who work in postpartum know that often we say to the depressed parent, even though you don't feel like smiling, smile anyway, because it will help. And when the baby smiles back, an almost autonomic exchange starts that actually helps reduce that cortisol stress elevation. Benefits beyond daily living. This was a study done in Sweden. The promotion of sensitive care, which serves as a buffer and protective shield for the infant and the infant's immature brain, and you'll talk more about that later, from potentially dangerous adverse experiences and physiological arousal brought on through substance abuse and misattunement between the parent and the child. So we know that even though we may not be able to reduce some of the risks, and Jesse will talk more about adverse experiences, that sensitive care and communication can be a mediator of risks. I like this idea because I think it's easily transferable to the clinician, and that a lot of what we try to do in helping a parent have a reflective stance is also the stance that I use. This is the clinician's deliberate, effort to assist the parent to take a reflective approach, to see her own mind and then be able to see her child's mind. Supporting reflective stance between the mother and the child acknowledges the underlying mental states, understand these as behaviors that will shift. This permits the clinician and the parent to see how states tell the narrative of what the child must be thinking and needing versus parental thoughts and feelings being imposed or intruded on the child. So the clinical task is to say, let's listen to what your baby is seeing. I think your baby is telling us that buffers against that inevitable projection that so many parents experience under distress. In summary, reflective capacity reveals the potential of a parent to see and respond to her child's mind. Reflective functioning is this active and continual process of holding both minds. Regardless of the clinical modality, reflective functioning becomes a critical intervention focus in perinatal mental health and a tool that we all use probably intuitively and I hope now more intentionally. Thank you.
So we have some time for questions. All right.
Thank you. That was a lovely, trip and fall here. Thank you. A wonderful, wonderful overview of obviously a very rich area. You know, one thing I'm struck by is it's obviously an area of interest of mine is that there's going to be variations in individual parents' capacities, not perhaps even because, how should I say this, not even perhaps because of a lack of desire or wish or even generational transmission in these capacities for reflective functioning, but perhaps at times because of inherent limitations in their cognitive capacity, perhaps due to substances, perhaps due to other limitations, chronic stress, PTSD, et cetera. And so there's going to be bottlenecks at times for parents. Do you have thoughts about that?
Yes. This one works bigger than the other. I think this is exactly what infant mental health works on, and Katie will talk more about this. Often when we think of infant mental health, and people will say, what, you're going to put the baby on the couch? Infant mental health is really working with the relationship. So when there are obstacles or limitations, and we can provide almost a supplementing. So rather than change the person's capacities, we supplement the person's capacities so that they get the outcome they need, which is a response from their baby. And that's where the new learning can happen, because the response from their baby then encourages them to do it again, even though they may not understand where it comes from. And that's why this research has been so interesting, because it's exactly looking at compromised adults and how by focusing this mechanism for interactive change becomes very effective. So a lot of times I do it with the client and in the process engage a baby so that it starts to feel safe. And very often people don't do it because it feels so unsafe. Any others? Otherwise, I'd gladly pass it on to an excellent interventionist.
Thank you, Dr. Gearity. Our next speaker will be Jessie Kuendig, a co-founder of the Mother-Baby program at HCMC, who will be dovetailing from Dr. Gearity's talk and discussing two-generation trauma healing, the Mother-Baby program at Hennepin County Medical Center.
Okay, great. Thank you so much for having me. And some of my greatest mentors, Dr. Gearity, Dr. Deeprink, are in the room here. I'm grateful to be here today and talk a little bit about the Mother-Baby program. And I hope to, so many stories come to life, you know, when you do this clinical work, just in hearing the themes around reflective functioning capacity that Dr. Gearity talked about. So I'll try to stick to my slides and not tell too many stories, but it does bring it to life. I'll just say, so I'll talk about the program a little bit and then talk about some of the ways that we do the mother-baby work every day together. I was thinking about what Dr. Gearity talked about of the baby and the mother together and providing a sense of safety. And I thought of two moms that we have right now where one of the moms, young 21-year-old African-American mom, significant history of trauma, 4-month-old baby, has a lot of this confusion about herself and her identity and what she's thinking or feeling. And I thought, I'm going to engage her thinking, brain, and we're going to talk about complex trauma and kind of name this because she was very overwhelmed in the group and sort of saying, I know this is more than depression. I know it is. I don't know what it is. I'm out, there's this evil cloud over me. And, of course, I'm thinking, complex trauma. I'll just explain it. And, you can imagine how well that went. It did not go well. She just was not in a capacity to take that in. But for her, she does find significant refuge in her relationship with her baby. Her baby can bring her back into the present, and she can be nurturing and attuned to him in a really amazingly beautiful way. And so when words limit, there's a limit to words, obviously, in psychotherapy, her baby is often able to bring her back not only to him, but to the group and to the process, and her healing. Kind of contrasted with another mom who, she's a teacher, first baby, she is what Dr. Gearity talked about. She's very confused by her baby, only 6 weeks old, high distress, even just being with her baby. So she brought her baby, and it was just her second day, and I came into the group room and I saw her, and she's looking over her baby in the car seat, just stuck, just kind of looking around. And I bent down and I said, is there something that I can help you with? And she said, well, I want to get the baby into the crib in the nursery over there. And I said, okay, what part of that can I help you with? And she said, all of it. Can you get her out of here without her making a sound? The baby making any sound was just too overwhelming and distressing. So for her, you can just see the difference in terms of the baby really, she isn't feeling safe in that relationship yet. Whereas the other mom, there is something very, grounding, for that other mom. So kind of two moms at the same time in the program. So we opened in 2013. So Dr. Helen Kim had, and Dr. Dieprink had, started a women's mental health clinic many years ago. And I think over the years, just seeing, sort of the, gap in care for, perinatal women, and wanting to start something more intensive. And so we opened with what we kind of consider a pretty traditional perinatal mental health mission, to save and improve lives by strengthening the emotional health and parenting capacity of mothers and families. And we started with these kind of 4 guiding values. Actually, we just recently added self-care because we realized how many of us were going up to the alternative medicine clinic and coming back down, just the importance of taking care of ourselves in this work. It's been almost 5 years, and I think pretty soon we realized that a more traditional perinatal mental health focus was limiting because many of our moms actually had a very significant history of early life trauma. And so, over the past year, we identified a new mission to reflect this trauma healing work, to embrace and strengthen young children, parents, and families through a safe, holistic trauma healing community grounded in social justice and lived experience. I think we're growing into this mission. Dr. Kim and Dr. Dieprink, they always tell us not to be too attached to anything, that we are constantly thinking about what we're doing and doing our own work and learning and growth. So if you think about on the continuum, on the green side, that we can imagine that all parents are stressed, but maybe not distressed. And so all parents deserve some kind of support. So we might think about early childhood family education or other kinds of supportive communities for parents. And on the far end would be a psychiatric admission. And so we were hoping to fill out the continuum a little bit. And so we first opened with the Mother Baby Day Hospital in 2013. We've had, around that many, we call them graduates since we opened. So pregnant women and moms with children 0 to 5 years old come to us for 5 hours a day, 4 days a week for about a month. So it's partial hospital level of care. So if you think about it's to avoid inpatient hospitalization or a step down from there. Moms with babies 12 months and younger bring their babies. And I'll talk a lot more about that. I think you couldn't do this work without that there. I think our moms that just have 2-year-olds, we also try to get the 2-year-old in at some point, or, the 5-year-old, just to see how that relationship is going. But there's so much richness in having the baby there and being able to do the work. I would say that some moms come in, you can imagine really heightened distress, and so they're not even really you can't even necessarily talk about the baby right away because it's like me, I am in so much distress. And then other moms come in and they're really very distressed by how the caregiving is going. And so the amount to which we support them and help them with their babies really depends on kind of where they come into us and their level of acuity. You can imagine some mamas, when we bring up we have our eye on the baby, of course, from the beginning, but sometimes if you bring up the baby to them maybe too soon, we might lose the mom. How can you expect anything more of me with my baby? I'm barely functioning as it is, and my baby already has so much need. How could you ask me to do more? So we notice we have some outcome data, which I just will say, just some pre and post tests that, moms better. And yet, some moms were still leaving, on the Edinburgh postnatal depression scale, kind of our average, post, score was 12, which would still be considered kind of in the at-risk range. And a good percentage with some, suicidal ideation still. So, we sort of, acute stabilization, but then thinking like it's a big drop from a 20-hour-a-week program to outpatient psychotherapy. So we started to develop some additional programs where sometimes mamas don't need the day hospital and they can come right into our step down program, or sometimes they step down from the day hospital. That program is only 6 hours a week, but we keep them a little bit longer, and then they see psychiatry on an outpatient basis, whereas for the day hospital, the psychiatry is built into that. I'll talk a little bit more about the curriculum. And then just kind of filling out the continuum there. So this is based on 362 graduates, but so about the majority are postpartum. About 12% are pregnant. What I like to point out about this slide is that you see that 70% are married or partnered, 51% have a college education or greater, and 44% are publicly insured. So for Hennepin County Medical Center, this is a really different demographic than the hospital is used to. And the hospital administrators were really happy with this in terms of our payer mix, was really good and one of the best in the hospital. But for us, really raised some red flags that clearly we are missing some of the most at-risk women. And so how can we do differently about that? And I'll talk a little bit about our efforts to start to do that. The other interesting thing about our demographics is when I'm going to show, so this is our, just an estimation of our discharge diagnoses. We are really starting to name more and more, complex trauma as a diagnosis. Particularly for moms that we have come in and they say, I have depression, bipolar, anxiety, OCD, PTSD, literally they will list 5 or 6 diagnoses and they feel so broken. And so thinking about this in terms of a complex trauma diagnosis and talking to them about that and what that means and what it looks like can be such a relief to moms to think this is about all of the things that happened to me, not that there's something so wrong with me. So I will say that also just in comparison to our demographics. So I think the moms we're seeing that needing that more intensive level of mental health support during pregnancy are in that broad postpartum range. Early life trauma is significant, whether you are partnered, college educated, or young and single. So I assume many people are familiar with the Adverse Childhood Experiences study. But this was a study done at Kaiser Permanente with the CDC that looked at to find out about traumatic experiences during childhood and how they affect adult health. What they found was that ACEs are common, that at least 63% had at least one category of childhood trauma, and these are like physical abuse, physical neglect, household dysfunction, kind of witnessing domestic violence, having a caregiver incarcerated. And over 20% experienced 3 or more categories of trauma. And that the higher number of ACEs that you had, the higher your risk was for many issues, not just substance abuse and mental illness, which you might think about, but also medical outcomes as well. So we wanted to look at ACEs in our own population, and so our mamas are in blue. And the CDC Kaiser women are in orange. So you can see that just over 60% of our moms have experienced 4 or more adverse childhood experiences. And then we also looked at Roy Wade in Philadelphia, looked at the expanded or urban ACEs, recognizing that a lot of the ACEs didn't, there were other adverse childhood experiences that were more prominent in urban areas or for people of color. And so looked at these adverse childhood experiences at the bottom. And these are just the moms in our program. So really high rates of those as well. And I think very troubling to us from I think not surprising probably to this audience, but troubling, obviously as compared to white women. Black women in our program were 6.7 times more likely to have experienced sexual abuse. These were all statistically significant. 6.3 times more likely to have witnessed domestic abuse, et cetera. And so we have been thinking this side here, the smaller triangle is sort of the typical ACEs triangle that talks about how adverse childhood experiences leads to early death. What we are starting to try to raise as much as we can at HCMC, but also with our patients, is the impact of historical trauma. And also what Sean Ginwright has called in the kind of the green line, PTSD. Not PTSD, so PTSD, post-traumatic stress disorder. PTSD is persistent traumatic stress environment. So recognizes the persistent stress that many families are still under, that their trauma isn't past, it's persistent. I think, again, talking about complex trauma as not a disorder, but distress, right? There's really good reasons why you feel as distressed as you do, that there's not something innately wrong with you, things have happened to you. And I think that can be very relieving to moms, to talk to them about it in that way. So in terms of curriculum, I found this to be, very helpful. So ARC is a trauma healing framework, which stands for Attachment, Regulation, and Competency. And I would say our curriculum fits pretty nicely into this framework. So we work on attachment. I'll talk the most about that in the time that I have. Regulation and then competency. And I'll talk about each of those a little bit differently. So for our psychoeducation, I feel like I have a story about each of these, but these are the different pockets where we do some psychoeducation every day. We do psychotherapy, and there was one particular story I wanted to tell. So you're familiar with Selma Freiberg and the ghosts in the nursery concept. Lots of different attachment interventions talk about this in a different way. Some of them talk about it as voices from the past or ghosts from the nursery. But I met with a couple, actually a physician and his wife recently who were really struggling with the 3-year-old daughter. And every time the 3-year-old, you can imagine what 3-year-olds, right? They want to assert their independence, their separateness, their ability to be their own person. And this was extremely triggering for the mom. And sort of every time the 3-year-old wanted to, for instance, the 3-year-old came up to the mom one morning and was swishing her spit in the mom's face. You know, the mom hates that and told her to stop. And of course, she kept swishing her spit. And then it got pretty ugly. You know, mom got really triggered and upset and yelled. And then the 3-year-old screamed and cried, and they were sort of at an impasse. But she was so concerned about her. It was motivated by such good intention that she wants a respectful child that, you know, respects her parents and kind of grows up to be a successful, healthy human being. But she was so indignant that if I don't shut this behavior down and if she doesn't listen right away, I'll somehow have failed. And so to frame that as a ghost from the nursery, and her response was, but I had a perfect childhood. I did everything my mom wanted me to do. And that sort of, for me, was like, there's some ghosts there, right? Because there was probably some pretty high expectations of her as a child that a 3-year-old just cannot meet. But framing it in that way for her really helped her understand, like, her whole body is going to want to make her shut that 3-year-old's behavior down. But as she can gain some awareness about that as a ghost from her nursery, then she can do a little bit differently. So we focus a lot on relationships. We do talk about ACEs and trauma. We talk about reflective capacity. We actually, talk about it and then help to notice it in the moment with the baby. So these are the different areas that we focus on. I would say safety, like Dr. Gearity talked about, is our number one goal. Part of the way we do that is through rituals and routines, not to stay sort of rituals and routines as a means towards flexibility. You know, the safer that patients feel and the more predictable things feel, then we can kind of soften those things as they stay with us. But we do a similar routine every morning and at the end of every day. We are using more movement to transition between groups. We have a Chi-Ji bowl that we hit at the end of the day, and I swear the babies know that when that Chi-Ji bowl comes out, they get to go home, right? I'll talk in Circle of Security. They use the concept of rupture and repair. This is a hugely has become kind of the language of the day hospital, because it's so helpful not only in terms of the parent-child relationship when there's rupture, and then how do you repair when maybe you've never had the experience of repair before, but also when I rupture with a patient, maybe they're willing to allow me to repair with them and have their first experience with that. It's helpful for me as a clinician because I have lots of practice with rupture, and therefore lots of experience with rupture, and then lots of practice with repair. Yes? Oh, okay. Yeah, I didn't explain that. So let me talk about Circle of Security, and I'll explain rupture. So Circle of Security is one of the 2-generation interventions that we use. It's the one we use is a 8-chapter DVD. And I think for some of our moms, just the experiencing it in the day hospital is enough for them to think differently about their children and their own experience of being parented. For some of our families that have more significant trauma, they're gonna need more than just Circle of Security. You can find that they can speak it actually sometimes really beautifully well, but this is still pretty difficult. So I'll just say that in terms of interventions. But so if you think about, this is all based on attachment research, but Dr. Gearity mentioned that with the parents are the hands on the circle, and the baby needs a secure base from which to go out to explore. And while the baby's exploring, we watch over them, delight in them, help them, enjoy with them. And then at some point, the baby is going to come back and needs a safe haven to return to protect them, comfort them, delight in them, and organize feelings. And it's the process of this happening over and over and over and over and over again that develops attachment security. And so we use this to talk about, and then we can notice with the baby in the room, where is the baby on the circle? Is the baby on the top exploring, or is the baby on the bottom and really needing you to help nurture? All parents rupture, and it can look like when my baby cries, but I'm upset myself, I say, "You're fine, stop crying." That would be a rupture, right? Because I'm not being that safe haven on the bottom to help them organize their feelings. I'm saying, go back out on the circle. Or maybe on the top of the circle, I get really triggered when my baby starts crawling away, and I interpret that as they don't want me anymore. They used to be my sweet baby in my arms, but now they just want to be out there. And so maybe I keep them too close. I don't want to let them go out to explore, and that would be a rupture also. So the more our mamas, I say you don't want to leave here without having some idea of maybe where your own parents struggled on the circle, because likely you're also to struggle there as well. And then the more awareness you have of that, the more possibility you have to do different, right? So if I know that, my favorite story I like to tell is when I studied abroad. I mean, I was in my 20s, but I called my mom. I was very sad, and she told me to read a book and eat some popcorn. So where might my mom be struggling? On the bottom. So it's just, that's good knowledge for me to have then as a parent, so that when my kids are sad, maybe I might want to shut it down. So this is really powerful. It's about all relationships, not just the parent-child, and we use it throughout the day in terms of how we talk about it and how we talk about our own relationship with the mamas as well. We use some of these other evidence-based parent-child interventions, some of them more on an outpatient basis. And I just do I have time to show a quick video? Okay. So this is a mama. I just have to disclose, I did not do the videotaping, but it's a lovely video, but very poorly videotaped. So if you can bear with me. I just can't get the mouse. There we go. So this is one of our mamas who gave us permission to show this, describing the circle of security.
I was in the Mother Baby Day program. My son is here too also. And I just wanted to tell you guys, today we're going to learn about the circle of security. Yeah. I learned about the circle of security, and now that they taught me this, and now that they've taught me this, I see it more frequently with my child and other parents and their kids. I think me and Demarion have we have a pretty safe circle of security. Basically, it is, you have to be the hands for your child to go out and explore the world. So that's this, support my exploration, which is like letting them go out and have fun. Don't always be like, no, come back, no, come back, I need you, because then they'll be afraid to go out and see what the world has to offer them. So when they're going to explore, you want to watch over them and delight in them and help them and enjoy with them. So if Demarion was playing with some toys, I'd be like, hi, I see you playing. I see you playing. Yep, I see you playing with those toys. And then when he's ready to come back in, I welcome him home. If he's crying, I have to try to soothe him or try to figure out what exactly is wrong with him. So that's me welcoming him home, which is fine. And you have to be their safe haven, which is protect them, comfort them, delight in them, and organize their feelings. So if Demarion was crying, I can't just be like, you're okay, Demarion. Like, Demarion, you're okay. It's okay. I have to be able to be like, what's the matter? And you're sad, and it's okay to be sad. And mommy knows that you're sad. And that way he feels more comfortable coming back to me whenever there is a problem in the world. He's not afraid. Yeah, I'm not afraid. Say, because mom's there. Yeah. So the parent always wants to be bigger, stronger, wiser, and kinder. But you don't want to be too bigger and stronger because you come off as scary. And you don't want to be too wise. You don't want to be too kind because then you're like a pushover. weak, then you're weak. Yeah, weak. So whenever possible, follow your child's needs, and whenever necessary, take charge. Because they need someone to take charge. Yeah, we need someone to take charge. Because we don't always know. Hi, my name is Nikki, and I was in the Mother Baby Day program. My son is here too also. And I just want to...
Okay. Yes, thank you. I can be done. I don't know how to get back to that. I just want to show you one slide. We had someone make a very fancy word cloud. That's okay. Okay. How do I get that back there? Oh, just skip all the way down. Okay, sorry about that. Oh, so what I love about this came from our satisfaction survey. What I love is that group is the biggest word, actually, that the power of the group is really unbelievable. Even when we have really great, significant diversity in the room, is really powerful. And I try to talk as little as possible when the group cohesion is going well. They're just a really beautiful support to each other. So thank you so much.
Questions at all?
Any psychiatric diagnosis then?
Not necessarily. Some of our moms, we just would name it also. So some of our moms absolutely have bipolar 1 or 2, or depression, but we may also name complex trauma if it will help therapeutically, if it makes sense and it is helpful for the mom in terms of conceptualizing herself and her identity and what's going on with her, we will use it. If there's a lot of shame in, 6 diagnoses, but we can call this complex trauma and that feels really relieving to her, we'll do that. Does that make sense? Yeah. But we would also name the other ones if they needed to be there and we're going to be helpful therapeutically and intervention-wise. Yeah.
Hi, this was really interesting. I just was wondering how long you continue to check in with the moms after they leave the program and what you define as success in terms of kind of their growth going forward.
Yeah. Sometimes we wish our program was like 5 years long, right? Because the day hospital is only 1 month. We do have them 20 hours a week, but that is a very, very short time. So we have a really strong discharge plan for every mama. We have had moms come back and have been readmitted when they've needed that. With the day hospital, we really look at acute stabilization. So are they, meeting some of those, kind of their daily functioning, the intensity and frequency of their symptoms is low enough to where they can utilize more outpatient services, but 100% of our moms still need a very significant amount of support going home. And we usually say it's sort of a soft discharge, like this is the plan that we have in place. And if it doesn't go well, we will make a different plan, right? So, yeah.
I had a question. Oh, sorry. Yeah. I had a question about if you have any type of programs available for people with perinatal loss so that they're not in the same room as moms who have living babies.
Yeah. So we could see them on an outpatient basis, but yes, it wouldn't, the group programs that we have right now wouldn't be appropriate for, we certainly have moms that have a pregnancy or, a baby now who've experienced loss. We've had moms who've come and they have the one twin, but the other twin died, but some sort of active pregnancy or a baby for the group-based programs. But we could see them outpatient, or we would absolutely connect with them to get them to the right level of support. Yeah.
I have a basic question.
Where are you? Oh, there you go. Okay.
What's about your average number of people in a group?
Yeah.
And then I have another question.
Sure. So, we have if you ever come to our space, it's very tiny. We're trying to get more space. You can imagine a lot of anxious, distressed moms and crying babies can get really overwhelming. And so our space is relatively small. So we really like 7 moms, and usually there's maybe like 4 or 5 babies. We have pushed it up to 9 moms at a time. It just gets really full. So that's where we like to stick.
Do you have, if somebody doesn't manage in this partial hospital, program, I'm not aware of, and I probably should be, of an inpatient mother-baby program within the Twin Cities.
No, there isn't. So, UNC has one, and I think maybe there's one now in California. I'm looking at Dr. Deeprink. And babies actually just visit, even at UNC, but it is perinatal women alone in the unit. I think they started out with just a few beds on the geriatric unit. But there isn't in the Twin Cities.
Okay, so the Abbott Northwestern program is also a partial hospital group-based program. Do we know?
They have a partial hospital, but it's not mother-baby focused.
I thought they had one. Then the other question is do you have a high dropout rate, or do you have a kind of an average number that you might lose of people you start?
I would say we're pretty good at keeping moms once they come. But it's getting moms through our doors. Like I showed you with our demographics, we're missing some of the most at-risk moms that just aren't going to come through our doors. So, yeah.
And then what do you do with people who really insist they want to see somebody individually? Because I've referred people, but I've been told we're a really group-based program. Do you have any options, or is that just not an option?
Yeah, we could talk individually about that. Yeah, we do have some outpatient work. It generally is the moms that have flowed from the more intensive programs, but we could talk for sure. Yeah. Thank you so much. I appreciate your time very much.
All right. Thank you, Jessie. Because I've had such a rich experience in my 4th year, I spent some time at Mother Baby, and I also spent some time at Abbott. It's not a partial hospitalization program. It's not tailored toward mothers, but there's a wonderful outpatient program with a lot of services there too. So our community is really lucky to have a lot of the reproductive services that we have for patients. So next we'll be transitioning to the biology of women with Dr. Brittany Howell of the Institute for Child Development, speaking to the maternal effects of the infant microbiome and neurodevelopment.
Perfect. All right. So I'm really super excited to have been invited to speak, just because I typically don't get to speak to people who are on the clinical side of anything. And I think that if we start to think about the kinds of topics that I'm going to talk to you about in the context of augmenting some of these therapies and approaches that we know are really effective, especially during the perinatal period, then we may get some much bigger bang for our buck as far as kind of helping, especially when we're talking about neurodevelopment. All right. So first, what is the microbiome? And so the technical definition for the microbiome is just the collective genomes of all of the microbes that are all over your body. And depending on who you ask, some people estimate that there's about 1 human cell to every 10 microbial cells on your body. So you are, by those numbers, only 10% human. It's kind of scary. There's actually a really great book titled 10% Human if you're interested in some of these topics. But what the microbiome really does is it enhances our body's ability to function. So it's adding 10 times the genomes that we already have. The vast majority of these microbes live in our guts, so in our gastrointestinal tracts. And when I say microbiome for this talk, that's all I'm talking about. There are certainly other microbiomes. The skin microbiome has been getting some press recently. Most of the research, though, has really been on the gut microbiome. And so we know that the gut microbiome is really important for digesting our food. For a long time, that's kind of the only function that we attributed to the gut microbiome, and that view is definitely changing. And we also know that it's really important for immune system development. So we know from lots and lots of work that if you disrupt the microbiome very early in life, then you end up with higher rates of asthma and other kind of autoimmune disorders. So what I'm going to talk to you today is how it's related to neurodevelopment. And part of the mechanisms through which the microbiome is related to neurodevelopment have to do with dysbiosis or an imbalance, because it's very important that we maintain a balanced microbiome. And so what I mean by that is the balance between three general classes of microbes. And when I say microbe, I'm including bacteria, fungi, viruses, and archaea if there are other biologists in the crowd. And so we can generalize these microbes into three classes. So the first are symbionts, and these are microbes that we know have positive health impacts. These are typically species that are ubiquitous and that really help regulate our immune systems and the other members of the microbiome. There are also commensal microbes. So these are bugs that we don't know that they're good or bad. They just seem to kind of be there. They may serve a function. I mean, they obviously serve a function, but they're not overly good or bad. And then we have pathobionts, which we know are bad. And so these are things, if you've heard about E. coli, depending on where it's found, can make you sick. The biggest player right now is C. diff. So if you talk about C. diff infections, that's definitely a pathobiont, which a lot of us are carrying, but because we have this balance and our symbionts and commensals are kind of keeping those pathobionts quiet, we don't see any health outcomes. However, if something happens and that balance is disrupted, and so we have fewer of our symbionts, and more of our pathobionts, then this can cause an increase in inflammation. Inflammation has gotten huge press recently because it's linked to all sorts of poor health outcomes, all the way from obesity through mental health. And what's interesting is there's actually a big overlap between the kinds of poor health outcomes that we see with inflammation and dysbiosis in the microbiome. So this is a very likely mechanism through which this is happening. And I remember when I very first started thinking about the microbiome in general, and I was really surprised at how many poor health outcomes were related to the microbiome, and specifically the gut microbiome. And so things that you would typically expect to be related to dysbiosis in the microbiome, so things like functional GI disorders, that makes sense, metabolic disorders, so things like obesity and metabolic syndrome, that makes sense to me as well. But then you start reading more and addiction pops up. And so alcoholics tend to have a dysbiosis in their gut. This could be because they're drinking more alcohol than they're eating healthy food. But there's some evidence that if you disrupt the microbiome, you can actually predispose, at least animals, to become addicted. So the dysbioses in the microbiome are also related to neurodegenerative disorders, things like Alzheimer's and Parkinson's, and then stress-related disorders, so things like depression and anxiety. And what I'm particularly interested in, being in child development, are the neurodevelopmental disorders. And probably the biggest link between dysbiosis and the microbiome is with autism. And so there's a huge literature growing to every day, actually, linking dysbioses in the microbiome with autism. And some of that work is actually happening right here on the U's campus. All right, so this is a perinatal health conference, and we know from lots and lots of really elegant work that mom is really essential to both establishing the gut microbiome and maintaining it, especially early in life. So we know from lots of work that mode of delivery, so whether a child was born vaginally versus surgically, can really set the stage for establishment of the microbiome and maintenance. So if you look at the schematic, we have, is there a pointer? There we go. So if you look on this first row, this 4-day row, so this is our vaginally born breastfed baby, and this is her mom's microbiome. This is our vaginally born formula-fed baby, and there's her mom's microbiome. And then we'll call this is the boy. This is our C-section baby, and here's his mom's microbiome. And at day 4 of life, for both of our vaginally born babies, they look pretty similar to mom's. This is the combination of her vaginal and GI microbiome. They look fairly similar. The abundance, so the number of microbes is very different, but and their diversity is lower, but it's made up of bugs that they got when they were exposed to the birth canal, basically. Our C-section baby, however, doesn't look very much like mom's vaginal or gut microbiome, and that's because his microbiome, at least at 4 days old, resembles mom's skin more than her GI tract or her vaginal flora. And so this actually, there's some reports, although they're pretty shaky, of increases in asthma rates in C-section kids. The animal work is a little clearer, but if you look at this, if we continue in time, so at 4 months, then the differences between all three groups actually become fairly distinct. So our vaginally born breastfed baby is still looking more and more like mom. Our vaginally born formula-fed baby looks kind of like mom, but then there are some other species that are coming in. We'll talk a lot about milk in just a second. And then our C-section baby still has some of those skin bugs, but starting to look more and more like mom. And then finally, by 12 months, everybody is normalized, meaning they do look like their mom's microbiome. So there are a couple things that I want you to get out of this slide. Number one, having a C-section does not mean you're ruining your baby's microbiome, okay? Bottle feeding your baby, you're not ruining your baby's microbiome. And so I personally have struggled very much with breastfeeding, and being a scientist looking at these things, I think stressed me out even more at one of the most stressful times in your life anyway. And when I was reading these papers, when my first daughter was born in 2013, and then this came out, and I was like, thank goodness, because I thought I had, ruined her life by giving her formula. But anyway, so that's one take home. And then the second is that we really need, if we can understand kind of what bugs are here and how we can get them there and keep them there, then maybe we can make this microbiome and this microbiome look like this one if we're considering this the gold standard. So one way that we can kind of think about delivering the microbiome or kind of shaping the microbiome is through milk or potentially through formula. So whatever we're feeding baby. But mother's milk is very specifically designed to not only nourish baby directly, but to nourish baby's gut. And so there are a couple ways that milk does this. The first is that milk actually has its own microbiome, which is kind of crazy if you really think about it. So there are microbes, mostly bacteria, and not a lot of them, but the ones that are there are important, that are actually in the mammary gland, and they move into the mammary gland prenatally. And there are a few mechanisms at play where so normally your gut epithelium, those cells are tight, really, really, really pushed together so that things can't leak in or out. We want to make sure that we keep that separate, right? During pregnancy, you can get a leaky gut. And that's important because that allows these dendritic cells of the immune system to actually reach in and sample bacteria from your GI tract as a mother. And they are actively, and this is, there's some animal work to suggest this. I don't know that anybody's shown it directly in humans. But anyway, those bacteria are directly shuttled by these dendritic cells up into the mammary epithelium, which is pretty mind-blowing to me. So your immune system is going down into your GI tract, choosing which bugs are important, and we don't understand at all how it knows, or does it know, is it random sampling, and then transports them into the mammary gland so they can be incorporated into milk and fed to baby. That's pretty mind-blowing. Additionally, and I'm not going to talk any more about this, but if you're interested, let me know, and I'd be happy to share some papers. There's this backwards feedback from baby's saliva, and there are actually receptors in mom's nipples that will then further kind of customize the milk based on baby's needs, which is crazy. At least to me. Again, I'm kind of a nerd, so that's kind of, I'm excited by a lot of things that don't excite most people. So another way, so I said they provide these bugs, right, for baby's gut. And then they also feed those bugs, the milk does. And so the vast majority of milk is lactose. That's not that surprising. Milk has lactose in it. The next highest component are fat, Again, we want nice, healthy, chunky babies. But then the third bit, which I always thought would be protein. This was before I actually learned about it, because you always think about macronutrients, you think about sugars, fat, protein. But the third most most abundant component in breast milk are actually these little tiny sugars called human milk oligosaccharides. And so I don't know if any people have heard of human milk oligosaccharides, but they're these little sugars that baby cannot digest themselves. They are just to feed bacteria in the baby's gut. That's their whole role. And they're specifically designed, or I shouldn't say specifically designed, they've evolved to feed a particular genus of bacteria called bifidobacteria. And so if you've ever looked at, there are tons of baby probiotics. So probiotics are just the bugs themselves that we know they have some kind of health benefit, and so we'll take them orally typically. But these HMOs will feed these bifidobacteria, which helps their population grow and pushes out bad bacteria. And we know actually if we give, I don't actually remember if it was bifidobacteria or another lactobacilli, if we give some probiotics to babies who are at risk for necrotizing colitis, it actually reduces mortality rates. So we know, and this was a study done in India, it came out last year in, I want to say Nature or Science, because it's a very simple intervention, but very, very powerful, or something, as simple as, because I think in our communities don't really consider that to be that high of a risk, but it is for a lot of the world. So breast milk, again, it contains its own microbiome, and the milk that moms make, they put a lot of energy into making food, not just for baby, but for baby's belly. All right. So what does this have to do with neurodevelopment? So up until now, I haven't talked at all about the brain, which is funny coming from me because I'm a neuroscientist. So you know this has to be important, right? So some of the mechanisms that we think are at play in how the microbiome talks to the brain, and this is sometimes referred to as the microbiota gut-brain axis, or sometimes just the gut-brain axis if you read other places. There are several ways, actually, that the microbiome kind of talks with the brain. The first are some of these microbes can actually produce neurotransmitters directly. So some of them will produce GABA, which is the primary inhibitory neurotransmitter in the brain. Some of them will produce serotonin, which is also one of the most common neurotransmitters. They can also affect the metabolism of some neurotransmitters. So indirectly, they can affect neurotransmitter systems. They certainly interact with the immune system, so they can cause changes in the kinds of immune cells that are present. They can cause increases or decreases in pro-inflammatory cytokines and other immune signals like immunoglobulins, things like that. Our microbes can also speak directly to our brain through those signals via nerve connections along the vagus nerve. And also the enteric nervous system has direct and bidirectional connections between the microbiome and the brain. So there are lots and lots of ways that the bugs in your gut and in baby's gut can talk to baby's brain. And why this is really important is because when this communication first starts is when the brain is actually developing, and developing very, very rapidly. And so we know from lots of work that when things are changing quickly, they're vulnerable to I consider it experience or exposure, however you want to conceptualize it. And this means both good and bad exposure, right? So if you are missing a particular kind of microbe, then your brain would be particularly sensitive to it. If you have an abundance of good microbes, then your brain is sensitive to it as well. So it's a two-way street, basically, is my point. But if you look at, and I'm actually not going to talk at all about the prenatal period, although it's super interesting, and there's a lot of evidence now that the microbiome is actually established prenatally, potentially. But if you look postnatally, so again, we talked a lot about delivery and how whether or not a baby is vaginally born or born surgically can have an effect, at least in where the microbiome starts. But if you start looking at birth, there are lots and lots of neural processes that are beginning. So at the time you have axonal and dendritic outputs. So those are kind of the dendrites are the inputs to the neurons and the axons are the outputs. So you have changes happening with both input and output for all of your neurons. We have lots of synapse production. So that's how those neurons are talking to each other, the connections they're making. There's actually programmed cell death. So we overproduce our neurons as babies and then we kind of prune them down based on the ones that we show we need based on experience. And then later on, as baby grows, we hit myelination and then some more pruning. And it's been pretty much agreed upon that around 24 months is where a baby's microbiome is pretty stable and reaches kind of adult levels of abundance as well as diversity. So what is really exciting to me is that this is changing. We talked about how milk affects it, but how do things like antibiotic use? There are lots and lots of kids that have lots of ear infections when they're really little. So how is that potentially affecting the microbiome and subsequent, communication between the microbiome and the brain and development? What about things like formula feeding? Is there a way that we can enrich formula or some supplements that we can give babies to kind of normalize their microbiomes? And there are some formula companies that are actually doing this now. I believe Similac, I think, they're adding some human milk oligosaccharides to some of their formulas to help feed the baby gut. But that's only half of it, right? So that's the prebiotic part, the kind of bug food that we should be eating to support those bugs. But if we don't have them there to begin with, so we kind of need both. You need probiotics and prebiotics. But it's really interesting that we don't actually know a lot about the connections. So we've done lots of work in brain development, especially early brain development, in animals. We know quite a bit from humans, but it's a little harder to get that kind of information. Nobody wants to or should volunteer their children to do histological slicing and those kinds of things. And we know a lot about the gut microbiome because these samples are real easy to get, right? Babies go to the bathroom a lot. And I actually just finished a project last week where we were compensating families for giving us dirty diapers. And you have no idea how many people looked at me like, are you serious? You're going to give me a Target gift card for this dirty diaper. It's like, I absolutely am going to give you this Target gift card for that dirty diaper. But no one has, or at least up until now, and there are a few groups working on it, I'm going to talk about in a second, gotten data on brain development and development of the gut microbiome in the same children prospectively and longitudinally. And so to kind of fill in that gap, we here at the University of Minnesota, so I work with Dr. Jed Elison at the at the Institute of Child Development. We are to be a part of the Baby Connectome project. So it's funny that UNC was brought up for collaborators. I'm not sure it's not the same group, obviously, but UNC is very mother-baby centric, which is one, I think. Anyway, so we have this joint venture where we're getting lots and lots of information about development in lots and lots of children. So we're getting behavioral measures, and I can answer questions if you guys are curious about what exactly we're collecting. We're getting and if anybody is familiar with the Human Connectome Project, we're getting Human Connectome Project compatible data, so we'll be able to do the same kinds of analyses as the Human Connectome Project. And with that data, we're getting structural. So those are these guys down here. If you've ever had an MRI, it's probably been one of these. And this is, I have to do a shout out. This is my 10-week-old. She's not 10 weeks old anymore, but this is her brain. I worked really hard. I'd like to share it. We're also getting diffusion information, so we can get information on the structural connectivity of the brain and then resting state functional MRI. So we can actually look at the functional connectivity of the brain as well. And of course, what really excites me and kind of my role in this project is really looking at some of these biological mediators of the gut-brain axis. So we're getting milk from every mom that's breastfeeding at every visit where she is providing any milk to her baby. We're getting formula if babies are receiving any formula, so that way we can actually measure things in the formula rather than guessing or going by what they say is in it. And we're also getting, oops, wrong way. Oh no. We're also getting fecal samples. And so we're going to be able to look at kind of all of these systems that can affect the microbiome, and we'll have brain imaging data and behavioral data in parallel. So we're going to be in a really great place to talk about not just, these are, oops, oh goodness, that these are happening at the same time, but how they're actually related. All right. And so in the future, I really hope to see this work move towards treatments. And again, I started by saying I think augmenting some of the behavioral therapies that we have is our best bet. And I 100% don't think you're ever going to solve all of our problems by changing a baby's microbiome. But I certainly think if we can help by normalizing, we should head towards that. And so I really want to drive home these points that the microbiome plays a key role in health and disease, and those go beyond just kind of GI issues, but to include mental health as well. That the development of the microbiome is strongly influenced by mom. We know that there is really a lot of bidirectional communication happening between the gut microbiome and the brain, beginning very, very early in life, potentially prenatally. And that ongoing studies at the University of Minnesota, and there are 2 other studies that are collecting somewhat similar data, one in Singapore and one in Finland, actually. And so we're in a really great place to learn a lot about these systems and how they change across time. So with the ultimate goal, at least in my eyes, being to help families do what every family wants to do, which is to have a happy, healthy baby that then becomes a happy, healthy child and a happy, healthy adult. So with that, I'm totally happy to take questions. And if you don't get a chance to ask your questions, or if you think of something later, feel free to shoot me an email and I'd be happy to answer them.
Thank you. I had a question about, are there any recommendations for feeding probiotics to kids? Is there any, and infants specifically, because I think they're available commercially?
They absolutely are. So clinically, I don't believe many doctors, so I give my daughter probiotics, but that's as a parent, not as a scientist. In talking to my pediatrician, she's been very supportive, but it's not kind of standard care. So they're partly because we don't have a good way. I talked a lot about prebiotics. We don't have a good way of ensuring that once we get those bugs there, that they're actually able to grow and thrive and do what they would normally do if they were being fed with breast milk. So I think we really need to work on the other end on how to provide those prebiotics. So I don't know if, adding HMOs is the best way to do that, or if there may be, other more kind of biochemical ways that we can feed those bugs. But yeah, just putting them there, we know doesn't work.
Sorry, and then one more question about the delivery, like if it's a vaginal delivery, but if the woman has had IV antibiotics for various reasons, like GBS, do we know what's happened? Is it like a completely cleared out gut that the baby?
So that's a really great question. And so my understanding is that that's not a huge issue, just unless, of course, depending on the length. Right? The length of time that she's on antibiotics. I think directly during delivery probably isn't that big of a deal because you're covered unless you're constantly sterilizing yourself. You're covered with all of your bugs all the time. And the vaginal and GI, the maternal GI microbiome changes right around delivery. So I'm imagining that your body's pretty good at making sure that the bugs are where they need to be. So I don't think that would be an issue. I haven't read anything about it being a big deal. Good.
My understanding is that Similac contains high fructose corn syrup.
So Similac is actually one of the few that doesn't.
Oh,
You are 100% right. The source of sugar in most formula is corn syrup. But for Similac, I believe it's lactose. So Similac is one of the, and I'm not sure, I think it's probably just cheaper to do corn syrup. And biochemically, they are digested the same way. So, I can't comment on what's better or what's not. But Similac is one of the few that is lactose, and they are adding human milk oligosaccharides. Because I think they are really trying to not just model the nutrition of milk, because you can get your sugars from different sources. But I think they're also trying to really match where those sugars are coming from. So they'd use lactose versus something like fructose. Great. Thank you guys very much. I appreciate it.
All right, so we'll take a short break. We'll reconvene at 2:50. There's refreshments out in the lobby, and we'll see you in a little bit.
Yeah.
Great parts of it.
Good.
Thank you so much for being here and doing this. So this, you can use the slide. Okay. If you need that, otherwise the arrows work. I'll set it up, but if you ever need to get back, F5 makes it on the screen over here. F5 like pulls it on.
Oh, okay.
I'll set it up for you, but in case you
So
get,
like for videos.
yeah.
Yeah.
Do you have it? I do. Okay. Maybe we should look at those. Sure. Let's see. Where do you know where they are? They linked?
Yeah,
here?
they're linked.
Okay. Oh, I think I did test your links earlier.
Fabulous. I may not show that one since I got showed this morning.
Oh,
but
yeah.
I'll check and see if imagine it's me losing the people that were here.
The majority,
So,
yeah.
let's go for that one.
That one?
Yep.
Okay, let's test it like from. Oh wait, this one right here. Cool.
Okay.
I'm actually going to X out of it because otherwise it like overplays some of the time. So I think then you can just X out of it. Yeah. Do you have another one?
Yeah, there's one more.
And I'll be sitting right there. That I'm definitely not an ED expert, but
Yeah, that was the next one.
Okay, cool. So I'll get you at 5. Cool. And then I have, I'll just kind of discreetly hold this up for you if it's helpful or not. But,
I do.
Yeah. There's one more before me, right? Oh, thank you. That's what I was right here. Yeah, but thank you.
Okay, so then
I just minimized these. Yes, Jones. Perfect. So it should be the very top one.
this one?
Yeah. Oh no! I just put prepare maybe. That's not good. Should I try? This happened last time I spoke in this room, and I had to redo the things. But I have my computer. If it will pull up on my computer, can we just hook my computer up?
Yes,
Okay.
maybe. Or could you email them to yourself?
Sometimes pulling up from email has been more successful.
Sure. Let's take it out of there and see. I may need the Wi-Fi. It's on the. I opened it on the flash drive last night. But I didn't see it.
And I can pull my computer up too.
So the good news is it opened on.
Oh,
Okay.
Perfect.
Email it to myself.
Yeah, and then if you can just pull your email up on here.
We got.
Happens all the time.
We don't work in the WILF often, so we were just trying to come up with all the options before we came in.
You have been disconnected from the meeting.